this computer, share my screen with you. Okay, so how many of you have come across neuroendocrine tumors? Almost everybody, isn't it? And the management of neuroendocrine tumors is slightly different from any management of an incidental solitary pulmonary nodule. So today I'm going to talk about neuroendocrine tumors, and then maybe later we'll talk about the what are the indications for solitary pulmonary nodules. So tracheobronchial neuroendocrine, no longer is the word carcinoid used, okay? The word carcinoid is a very, very old terminology now. And with the new histopathology classifications, you're actually supposed to call it as NET tumors, N-E-T. Or a T-NET, that is a tracheobronchial neuroendocrine tumor. So the word carcinoid now is actually obsolete in the new histopathological classification that's come out in 2016. All right? And so that's important for you to know, particularly in the exam. You must be able to tell that the word carcinoid is still used, but it is not just carcinoid. Carcinoid doesn't mean anything. So it's actually neuroendocrine tumors. Okay. So let's start talking about neuroendocrine tumors. So they, as we know, originate from the neuroendocrine cells. So these are tumors which come from primarily a cell which is from the neuroendocrine tract, and usually 60% of them are present in the digestive tract. Okay, so most commonest site of carcinoids, if that's what you want to call it, is in the digestive tract. Tracheobronchial are about 25%. So they are pretty common actually. If you look at the total number of NET tumors, quite a few of them do come up in the airways, and we see them quite a lot. And so the word to be used nowadays is bronchial, bronchial NET. And I have personally seen also neuroendocrine tumors in the thymus. And in fact, just 10 minutes ago, I received a message from somebody on WhatsApp who was asking me about how to operate on a Thymic NET. And I'll talk about it in a minute. I'll share that with you guys. So most of these actually are incidental findings. They never come up as, symptomatic. They are either they present with little bit of shortness of breath. For many, many years, these people have been treated with as asthma patients rather than, somebody with an endobronchial tumor. And so very often they've been receiving inhalers, nebulizers, and very rarely do you realize that actually there is something within the lumen of the airway that is blocking the tumors. So most of them will present with an asthma type of shortness of breath. And almost invariably, the history will be that they have been treated with nebulizers. They do come up with recurrent chest infection, and this is very easy to understand because anything that grows within the lumen actually prevents you from coughing out all the phlegm and things like that. So because of the retention of phlegm, you're more likely to get chest infections. So that's another presentation that these guys come up with. Occasionally, they'll come up with pressure symptoms. And the pressure symptoms could be either pressure on your airway, which we said, stridor, or there could be pressure on other surrounding structures, like there could be pressure on the esophagus, and that may give rise to difficulty in swallowing. Or there could be pressure, if it's present at the thoracic outlet, there could be a thoracic outlet syndrome sort of picture. But predominantly the pressure symptoms is an airway pressure symptom. So stridor or difficulty in breathing is one of the commonest things that we see. And then of course hemoptysis, because these are very, very vascular tumors. And when they are present within the endobronchial tree, they can actually bleed. And that's why very often the pulmonologists who do a bronchoscopy are very scared to biopsy them because they really are quite, they bleed a lot. They are very, very vascular. So hemoptysis can be one of the presentations. So these are the 4 types of presentations that you'll get clinically. Now there is something called a syndrome. So these tumors can be part of a syndrome. That means there are other tumors in the rest of the body. So you can get what is called as a Cushing syndrome, which is present in 1 to 2% of people, and we'll talk about it. We can get ACTH production. In Cushing syndrome, you can get ectopic production of ACTH. You can have a acromegaly, which gives rise to ectopic growth hormone releasing GHRH problems. So you have an excessive release of the growth hormone. And rarely you will get what is called as a carcinoid syndrome. And I'll talk about each of these in a little bit, okay? So just stay with me on that one. Now, these are quite simple things. Commonly, you will get a patient who gets an asthma-like syndrome, getting recurrent chest tract infection and not being picked up by the pulmonologist, and they will present with a chest X-ray. And the commonest finding on the chest X-ray will be either something seen obviously bulging in the mediastinum, or more commonly, what you see is a collapsed consolidation of a distal airway. So commonly, if they're present in the right upper lobe, you will see a collapsed consolidated right upper lobe, or you will see bands of atelectasis in the distal airway, secondary to endobronchial obstruction. And so the chest X-ray then leads to the next investigation, which is the CT scan. And I think CT scan is pretty diagnostic. If you look carefully, you will find that these things will have an endoluminal area, but also they will have an extraluminal growth. So in a CT scan, you have to analyze both the mediastinal windows, and you also have to analyze the lung windows, because you want to know what is present within the bronchus, but more importantly, you want to know what is present outside the bronchus. And another thing that you have to look for is the presence of mediastinal lymphadenopathy, because these are typical carcinoids and atypical carcinoids. That was the word that was used previously, not anymore. But in an atypical carcinoid, they are more likely to metastasize to local lymph nodes. So in a CT scan, you will also look for mediastinal lymphadenopathy, and that will be done obviously in a mediastinal window. Bronchoscopy is pretty diagnostic. The view in a bronchoscopy is very classical, and I'll show you that in a minute. You will see this rounded, red, angry looking tumor with a lot of vascularity coming into the endobronchial area, and that will usually be obstructing the distal bronchus. So bronchoscopy is quite a good diagnostic tool to identify endobronchial carcinoids. Very often, just by looking at it, you can say this is a carcinoid. But pulmonologists are usually quite scared to biopsy it, obviously because of the risk of bleeding. So they come to us for biopsying, and what we do is rigid and a flexible bronchoscopy. Now, what happens in that scenario is when you do a rigid and a flexible bronchoscopy, when you biopsy it, you can stop the bleeding pretty easily, because you can use adrenaline filled swabs, you can use local diathermy, you can use laser. So not only can you do a diagnostic procedure, but very often you might also be able to do a therapeutic procedure, which means you might be able to resect it. If it's just a simple polypoidal carcinoid lying within the bronchus, you might be able to snare it out, or you might be able to laser it, or you might be able to stent it. So there are a lot of things that you can do. So surgical bronchoscopy is much more sort of indicated in these sort of scenarios. There is something called as a octreostite scan, which is particular for a carcinoid. But nowadays, with the onset of DOTA imaging, that is DOTA PET imaging, this is a particular dye which attaches to the chromogranin crystals on the surface of the carcinoid tumor. And this is the recommended modality. So nowadays, if anybody asks you whether you should do a normal PET scan, this is not the FDG PET scan. This is a DOTA PET scan. DOTA is a short form for one of those long names of the dye that is used, and this is specific for carcinoid tumors. So always you must say, I would do a DOTA PET scan. And the reason why you would do a DOTA PET scan is not just to identify primary tumor, which means to identify intrabronchial and extrabronchial extensions, but you also want to do a DOTA PET scan to look for tumors in the rest of the body, because sometimes these carcinoids, as we said, can be part of a systematic syndrome. And very often you will find a second carcinoid in the gut, or you might find a second carcinoid somewhere else. So DOTA PET scan is the one that you have to see. And also not only look at distant metastasis, you also want to look at lymph node involvement in the carcinoids, because prognosis completely depends on the level of lymph node involvement. So these are the 4 or 5 investigations that you must talk about when you do when you have a case in the exam with a suspected carcinoid. Okay, so this is the kind of CT scan. Can you see that there is an endobronchial lesion which is obstructing about 70 to 80% of the area? But what is important is there's something outside as well. Okay, so you've got to look at not just this, but also what is present outside. And when you do resections, you have to do complete resection. So that's quite important that you get rid of the whole thing, not just endobronchial areas. Okay, so it is quite important that you identify the intrabronchial part and the extrabronchial part. And always there will be distal atelectasis and collapse and consolidation. Okay, so it's quite important to identify that. Here is a PET scan. This is a DOTA PET, which is showing the carcinoid tumor, and there is collapse consolidation distal to it. Okay, so this is not just a simple PET. This is actually a DOTA PET, which is showing you this lesion quite nicely lit up. Okay, so we said this. Bronchoscopy is the diagnostic tool, but nowadays we also have access to EBUS and EUS. And the reason you want to use EBUS and EUS in these scenarios is because you want to biopsy the mediastinal lymph node, because that will give you exact staging of these tumors. Occasionally, if it's a peripherally located lesion, then a simple CT guided biopsy will be enough for us to make a diagnosis. Okay, so it's quite important. So this is how a carcinoid looks. All of you must have seen it in your clinical practice. This is a classic look of a carcinoid. Okay, so this is like a ball lying in the airway and blocking the airway. In fact, most of the times, if you are a good bronchoscopist, you will be able to go on the side of this tumor and look at the airway behind. So very often you can actually examine the distal airway as well, even though the carcinoid may appear as if it is blocking the airway. But 2 things you have to look for. One is, A, you have to biopsy it because you want to know what you're doing. More importantly, you've got to look for the base. The base is quite important because there are 2 types of base that you can get. One can be a pedicled base, which means it has a small pedicle. And if it's got a pedicle base with no extra bronchial involvement, then actually endobronchially you can remove it. And that might be therapeutic for the patient. But most of the times you'll find that it has got a broad base. Can you see here? It's got a broad base. So it's involving almost 1/3 or half of the circumference of the airway. And when you have something like that, then these are not amenable for endobronchial treatment. These need a surgical resection, because not only do you have to take this out, but you've also got to make sure that no defect is left behind. So it's quite important with bronchoscopy. And then, of course, we can use EBUS. There are 2 types of EBUS. You can use the radial EBUS or the circular EBUS, and that will give you not just the tumor, but it will give you the lymph nodes. So what you're looking for is the lymph nodes, okay? Now, what about the blood tests that you can do in a carcinoid tumor? Because these are hormone-secreting tumors, you got to remember what is the disease that you're suspecting. And then depending upon what is the disease that you're suspecting, you have to do the required test. So if you are if you're suspecting a carcinoid with a carcinoid syndrome, then you have to look for urinary HIAA and serum chromogranin A levels, okay? So urinary HIAA and serum chromogranin levels are the diagnostic feature. They will be elevated when you're talking about a carcinoid syndrome. When you're talking about a Cushing syndrome, that means it's part of a neuroendocrine syndrome, but not a carcinoid syndrome. then you've got to look at serum cortisol levels. And most of the time, the tumor will be present in the pituitary. So there'll be a small pituitary adenoma associated with a neuroendocrine tumor in the tracheobronchial tree. So you got to look at serum cortisol levels. There is something called as a meterapin suppression test. There's something called as a dexamethasone suppression test. And the serum cortisol level is best measured when you do a petrous sinus venous sampling. And that will give you the best levels of the serum cortisol, okay? And of course, a CT head. That's quite important. So you need to look for the ACTH, and then you need to look for serum cortisol level, okay? And I can't describe more details of these two tests. These are all, biochemical tests done by the labs. And I personally don't know the details of these tests. But you need to know in the exam. You just have to say meterapin suppression test and a dexamethasone suppression test. What they do is they give you this drug and then they look for suppression of the serum cortisol and the ACTH level. And both of these will actually come back as positive. Okay. Sometimes you are also dealing with a growth hormone, GHRH syndrome. And if you're dealing with a GHRH syndrome, then you got to look for serum GHRH levels. Again, the best level will be from the petrous venous sample. So you've actually got to do a petrous venous sample. Don't ask me how they do it, but there is the neurosurgeons and the neurologists do it. You got to look for the growth hormone. You've also got to look for the insulin-dependent growth hormone 1. This is specific for a GHRH syndrome. And of course, you've got to look for GTT because this syndrome particularly causes disturbance in the insulin metabolism and in the metabolism of the glucose. And very often the GTT will show high levels of glucose in the circulating system. And of course, you got to do a CT head to look for any tumors in the pituitary or rest of the head. So these are a few specific things in a carcinoid tumor that you've got to remember. So GHRH syndrome and the Cushing syndrome. These are two syndromes. They're part of neuroendocrine syndromes. Okay, so we've spoken about this. The Chromogranin A, which the ones that we usually see are usually part of the digestive and the neuroendocrine area. And these will have Chromogranin A elevation. And they have prognostic significance and can be used for monitoring as well. So the level of serum Chromogranin A is a good biomarker for telling you, A, whether the tumor is active, B, once you've taken it out, the level should drop dramatically. So it tells you that you've completely taken it away. And C, you do it as a follow-up for these patients. And in the follow-up, if Chromogranin A level rises again, that means a new carcinoid is forming somewhere else in the body. So it's used not only for prognostic significance, but also for monitoring of the recurrence of carcinoid. So you got to look for carcinoid recurrence in the rest of the body. Also, you got to scan the lung to make sure nothing is growing back in the area that you have operated or in any other new areas. So this is important to remember that Chromogranin A is a good biomarker for follow-up in carcinoid tumors. Okay, all right. So higher level of Chromogranin A suggests a higher tumor burden. So it's a direct correlation between the levels and the size of the tumor. So it's a very, very good tool for monitoring and for preoperative diagnosis for this. Okay, they are particularly elevated in renal and hepatic failures. They are elevated in PPI inhibition therapy, and they have to be used in conjunction with imaging. Okay, so you have to use your octreotide scan and understand. So if they are elevated in a patient with a chronic renal failure, it doesn't mean that he's got a huge carcinoid sitting somewhere. It just is biochemically there's a problem because Chromogranin A is not being cleared by the body, or there is a liver failure where Chromogranin A is not being metabolized, and that is why it is elevated. So you've got to interpret the Chromogranin A level carefully in the background of other diseases. And also remember, if a patient is on omeprazole or esomeprazole, then these levels may be elevated. So does not directly relate that a high chromogranin A in a patient taking PPI means there's a big carcinoid tumor. So this is important to understand, okay? Sometimes we see what is called as a thymic net, and I will share this with you in a minute. So these thymic neuroendocrine tumors actually originate from the Kulczycki cells. So remember this word, Kulczycki cell. These are specific cells present within the thymus, which are responsible, more commonly seen in males. And 2/3 of these patients are symptomatic. That means they will show some symptoms of a carcinoid syndrome or a carcinoid tumor, but they will not usually show myasthenia gravis. Sorry, they are not associated with carcinoid syndrome and not associated with myasthenia gravis. Okay, so this is quite important that this is not a cause of myasthenia. Thymomas are directly linked with myasthenia. Carcinoids of the thymus are not linked with myasthenia. The importance of preoperative diagnosis of a thymic nodule, whether it's a carcinoid or it's a thymoma, is important because surgically the technique changes. With a thymoma, you are really worried that you should not injure the capsule of the thymus, of the thymoma, because that will cause seeding of the tumor, and a stage 1 will become a stage 4. We discussed that in the past. But in a thymic carcinoid, they are very well encapsulated, and most of the time there's a very nice space between the tumor and the rest of the tissue around it, and you can actually dissect into the space and take it out en masse. So these are easier to dissect than a thymoma. A thymoma, you've got to use what is called as a no-touch technique because you do not want to endanger the capsule. In a thymic carcinoid, you are in a slightly better situation where you can actually, you don't have to worry so much about damaging the capsule because it's quite well encapsulated and it's not easily damaged. This is a tumor which I took out from a mediastinum, and I did not actually, to be honest, think that this was going to be a carcinoid. All along, when I looked at the CT scan and I looked at everything else, it looked like a teratoma to me, because if you look carefully within the tumor, you will see it's multiloculated, multilobulated, has got all various types of tissue in it. And this was and look at the capsule. The capsule is so well formed that the chances of breaching the capsule are not much. It really scoops out like a laddu, as we call it, a laddu. It just comes out very easily. In fact, today, when they asked me, this surgeon who has written to me, he's got a 13-centimeter tumor in the anterior mediastinum, exactly like this, but slightly bigger. This is 10 centimeters. He's got a 13 centimeters. And he has asked me whether he can take it out by VATS. Now, normally, if this was a thymoma, I would have told him, try not to do it by VATS, because if you breach the capsule, you will get pleural dissemination. So do it with an open sternotomy. But he's got a preoperative diagnosis that this is a thymic carcinoid. And because of that, I've actually advised him that don't worry about it. Go in by VATS, make an assessment. You will be pleasantly surprised that actually this tumor will be well encapsulated and it might come out as a whole without having to open the sternum. So the preoperative diagnosis is very important. It changes how you approach this. If this was, I had suspected that this was a thymoma, I would have been more likely to actually do a sternotomy. But because I was thinking germ cell tumor, I was thinking teratoma, then I was quite happy to do it by robotics. And this one I did by robotics actually. So it is important to know preoperatively what is happening. Very often the thymic neuroendocrine tumors are part of paraneoplastic syndromes. They may be associated with Cushing syndrome, but if it is associated as a part of a paraneoplastic syndrome or a Cushing syndrome, then it's not a good prognostic factor. These guys will not do well because there is a high chance of recurrence and high chance of this coming up in the rest of the body. So that's not a good prognostic factor. If they are isolated lesions within the mediastinum, then they have good prognosis. You take them out and that's it. The patient gets back to normal life. Okay. Now this again, see this one. This looked to me like a thymoma. And we had again not taken a preoperative diagnosis with a CT guided biopsy because it was deep seated. And we did a thymectomy like we would traditionally do. And this one came back as a thymic carcinoid. So very unusual, but every so often you're surprised by the histopathology. Very often thymic carcinoids can develop local recurrence or metastases. And if they, as I said, if they are associated with other syndromes, then the overall cure rate is not very good. Okay, so it's important to remember this. Now, IASLC and WHO have actually classified these according to the TNM staging, and that is depending upon the size of the tumor, depending upon the nodal involvement and the metastatic involvement. So you've got various stages, stage 1A, 1B, 2A, 2B, 3A, 3B, and stage 4, okay? And so this is something, usually WHO TNM staging is not used very dramatically in the management of carcinoids or neuroendocrine tumors. What is used is the histological grading. So histological grading is more important than the WHO staging in thymic tumor, in neuroendocrine tumors. And this is something that you got to know, because histological grading is grade 1, grade 2, and grade 3. And this slide is important because you've got to know what is the mitosis per 10 high power field and what is the level of necrosis. And if there is less than 2 mitosis and there is no necrosis, that's grade 1, which is a low grade. So that is a good outcome. This is where what we used to call as typical carcinoid tumor, they lie. So nowadays, typical carcinoid tumors are called as G1 neuroendocrine tumors. Okay, so the word and the terminology has changed. So if you've got a typical carcinoid, you have got G1 neuroendocrine tumor. If you've got atypical carcinoid, then you're looking at G2 and G3. Again, with G2, there is more mitosis and some evidence of necrosis. And with G3, there is much more necrosis, okay? And the prognosis of recurrence and prognosis of long-term survival decreases with a G2 and a G3 as opposed to a G1, okay? So it's quite important. And this is the sort of histology that you see. You will see nests and you will see trabeculations within this tumor, and you will see no necrosis in a G1 endobronchial tumor. When you come to a G2, you will see evidence of nuclear pleomorphism and mitosis. So this particular lymph node, this particular nucleus looks different. It looks, if you look, this is nice and circular, this is nicer, but this one and this one is starting to show nuclear pleomorphism. So it's quite important to understand what is G1 and G2. So G1 is typical carcinoid, G2 is atypical carcinoid, and G3 are now called as neuroendocrine carcinomas. So these behave like a tumor, like adenocarcinoma of the lung. They behave completely different. So G2 and G3 come within the atypical carcinoid area, but G3 is now classified as a carcinoma rather than a carcinoid, okay? So they have more chance of metastases and more chance of recurrence when you operate on them. So it's quite important to know these things, okay? All right, so what is the treatment? The treatment is surgery, and surgery is the gold standard of treatment in carcinoid tumors, in neuroendocrine tumors. And the intention of surgery should be A, curative. You must always try and take away all of the tumor that you see in front of you. Usually, if it is a G1 tumor, you take it away, there is no recommendation for any adjuvant therapy. Okay, and that's the important thing, because these are not very sensitive to radiotherapy and not very sensitive to chemotherapy. About 25% of them actually respond to chemotherapy. However, if I'm dealing with a G2 or if I'm dealing with a tumor in which I have left behind some microscopic invasion in the bronchial margin, then I will send them for further chemotherapy. And I have even used local radiotherapy to the bronchial stump to prevent or reduce the risk of recurrence. However, we do not have a long-term randomized controlled trial which has shown benefit in these scenarios. But so clinically, A, we operate. B, if it is an atypical carcinoid with evidence of lymph node metastases, then I will send them to the oncologist who will actually discuss chemotherapy with them, and they will give them some chemotherapy. But the thing is, you've got to remember, only 25% of these carcinoids actually respond. And if I've got local microscopically positive margin, then I send them for radiotherapy. And nowadays I send them for radiotherapy because radiotherapy has become much more advanced as compared to previous studies. So in the previous studies, they used to say there is no role for radiotherapy because it causes more complications than curative intent. But nowadays, with the cyber knife coming into picture and with SBRT coming along, I specifically refer them only when there is a margin positive bronchus. And occasionally you might get a histology which says there is microscopic involvement of the margin. So what are the surgical treatments available to you? The principle of surgery in a carcinoid tumor is lung sparing. Okay, so you always try to spare lung. So you try to do minimum that you can do when faced with a carcinoid. So if it is a peripherally located carcinoid, you can safely do either a wedge resection in a patient who is not fit for a lobectomy, or you can even do a segmentectomy. And as long as your margins are free, then you have done a good operation. If the carcinoid is centrally located, and this for me is a very important point because very often these carcinoids are present in either the right main bronchus or they come from the right upper lobe and will flop into the right main bronchus, or they may be present in the left main bronchus. Now, in these scenarios, you do not want to do a pneumonectomy. The last thing you want to do is take away good lung. So I will very often look to do a sleeve lobectomy or a sleeve resection. Now, the difference between a sleeve lobectomy and a sleeve resection is, if the tumor is completely in the right main bronchus, I'll just chop the right main bronchus, take it out and re-anastomose the right main bronchus to the right main bronchus. Thereby, I will save the upper lobe, middle lobe and lower lobe. That is a sleeve resection. A sleeve lobectomy is when the tumor is coming from the right upper lobe, plopping into the right main bronchus and physically blocking the bronchus intermedius. In this situation, I will actually open the right main bronchus, take away the right upper lobe along with the tumor and re-anastomose the bronchus intermedius to the right main bronchus. So this is a sleeve lobectomy, means you have taken away the right upper lobe, but you have saved the bronchus intermedius. So in my personal practice and in almost all the international leaders who are around the world, most of us will try to avoid a pneumonectomy over a sleeve resection, okay? And most of us will go for a sleeve resection. And nowadays, I would do most of this by either VATS or by robotics. In fact, robotics, it's a very, very good technique to do particularly sleeve lobectomy, because suturing with a robot is beautiful. And I'm hoping to do a lecture for you guys about robotic surgery and what is the benefit with robotic surgery. And there I'll show you the videos of how we do a sleeve resection by robotics, okay? So that for me is a typical this thing. Now, sublobar resections, we spoke about it, unisegmentectomy or a multi-segmentectomy. So if it is isolated in the apical segment of the lower lobe, I will do a apical segmentectomy, apical lower segmentectomy. If it is in the common basal segment, then I will do a common basal segmentectomy trying to leave behind whatever lung I can. So multiple segmentectomies are possible depending upon the location of the tumor. Very often these are present centrally, and you've got to be very careful. See this one, this is in the left main bronchus. And this one was right there, and we actually managed to take it out by robotics and do a upper lobectomy. So we did a sleeve upper lobectomy and got it out, okay? And we reattached it. This particular case, I think, is an old one where I did by VATS, but now I've done a few where I've done it with robotics. And I have a video of that robotics, and I'll try to show it to you. I'll try and show it to you in a minute. What about lymph node involvement? Personally, whenever I do a resection of any mass in the lung, I prefer to do a systematic mediastinal nodal dissection. That's my personal choice. But some people will do what is called as a systematic mediastinal lymph node sampling, which means they will go into every station and cherry pick each of the station and send a representative sample. To be honest, there is no difference in the outcomes between mediastinal lymph node sampling and mediastinal lymph node dissection. If you look at the ASCOG 300 study, which was published in the US, they looked at the differences between dissection and sampling. And they found that there was no prognostic benefit of a dissection over a sampling. So if in the exam you say, I will sample all the lymph nodes, that's okay. If in the exam you say, I will dissect all the lymph nodes, that's okay. The philosophy behind dissection is that you actually get more lymph nodes, you get more representation, and you will get a better staging of the tumor. But if you are not confident about doing a whole sampling, that's okay. And you can say, I will only do a sampling, not a dissection. Because when you do a dissection, there is slight risk of injury to other structures, particularly injury to the recurrent laryngeal nerve on the left side and injury to the thoracic duct on the right side. So these are two things that you can potentially injure. In fact, you can injure also the recurrent laryngeal nerve on the right side if you go very high trying to take station 2, the highest mediastinal lymph node, because that is where the recurrent laryngeal is positioned on the right side. When we do dissection on the right side, we always take out station 2, 3, 4. So this is upper paratracheal. This is anterior mediastinal or pre and post vascular. This is lower paratracheal. This is subcarinal. This is paraesophageal. This is inferior pulmonary ligament. This is hilar. Okay, so on the right side, we'll usually get that. And 11, 12, 13, 14 comes with the specimen. So this is where you get, this is the SVC and this is the azygos. When you dissect out this area, you get station 2 high up here. And when you go behind the azygos, you get station 4. So this is the right side, okay? And then laterally, if you open, you will get station 7. So this is the right main bronchus coming here and left main bronchus, and between them you will get station 7. 8 is the esophagus, which is lying here, and 9 is the inferior pulmonary ligament. So this is just a diagram to show you where exactly you do it. This is on the right side. On the left side, 2 is very high because usually there is a subclavian artery and things like that, and it's very difficult to get into station 2 on the left side. Okay, so this 2 is usually out of reach. 3 can be got because this is where 3 is. It's next to the artery, so you can get 3. 4 is low down. Again, you need to be very experienced to get into this area to get 4. So in my personal practice and Khalid Aimer, both of us usually get into 4. 5 and 6 are easily accessible. They are pre-aortic and aortopulmonary window. Okay, so pre-aortic and aortopulmonary window. So subaortic and the para-aortic. That's what they're called as subaortic, para-aortic. 5 and 6. Then 7, again, you need to be very experienced to get into this area. It's not an easy area to get into from the left. And then 8, 9, 10 are easily accessible. Okay. So there it is. This is the inferior pulmonary ligament you're dissecting off. This is 9. This is 9. The 8 will be here next on the esophagus. And then if you lift up this is the vagus coming down. This is the descending aorta. You got to cut all these branches to lift the whole lung up. And this is the bronchus coming from the back. And when you get into this area is when you will get the subcarinal. So look here carefully. So we are lifting the whole lung to the front. We are cutting all these bronchial branches of the vagus, and we are getting into this space. And this is the space where you get in, and you will get the subcarinal. In fact, the dissection has to be so clear that you've also got to see the right main bronchus from the left side. And then this is, of course, the station 5 and 6. So this is phrenic in front, and this is vagus in front. And the important thing that you got to remember is in this area where the recurrent laryngeal nerve comes, okay? So it's important to know that the recurrent laryngeal swings along here. This is the ductus arteriosus, or, the ligamentum arteriosum. And you got to be careful about the ligamentum arteriosum. Just next to it is the recurrent laryngeal nerve. So when you do these dissections, you need to be very careful about what you're doing. Okay, so that's about the surgery. So surgery is straightforward, either a lobectomy, segmentectomy, or wedge. And if it is centrally located, you either do a sleeve resection, which could be just a sleeve resection, or a sleeve lobectomy. You never ever try to do a pneumonectomy when you're dealing with carcinoids, okay? I've had a couple of patients who were offered pneumonectomies in other institutions, and they came back, and we actually managed to do it by sleeve resection. What about people with isolated liver mets? There is every role for surgery with isolated liver mets. You do the curative surgery from the chest, and then you do resection of the liver metastases. And that is supposed to have quite a decent prognosis. Okay, and then you might have to do palliative surgery depending upon what is there. As I said, radiation has some role in metastatic disease nowadays with the new ones. So in my personal opinion, I do it only when the margin is positive, or if the patient is unfit for chemotherapy. That's when I will do that. Within the liver, what you can do for these metastases is, A, you can do a debulking surgery, which means a segmentectomy of the liver, or you can use radiofrequency ablation. This is a very good technique to tackle liver metastases, not just in carcinoid tumors, but also in other colorectal metastases and things like that. So RFA is increasingly being used as a technology to tackle liver metastases. There is a role for cryoablation, using cryotherapy to kill the liver metastases. Some people are using laser therapy. And also there is a role for therapeutic embolization, which means the interventional radiologist goes in there and embolizes the artery and the vein that is supplying the metastases. And then the metastases necroses and comes out. And rarely you will do a liver transplant for metastatic disease. In my particular center at Medanta, they have a good record of liver transplants, and they will offer these patients not just a single metastasis, but if they've got more than one metastasis and the primary is very well controlled, then these patients may potentially be candidates for liver transplant. Of course, they've got to have systemic chemotherapy before they will be taken up for liver transplants to make sure that there is no floating cell within the blood, because you don't want recurrence after the liver transplant. A lot of carcinoids can be treated endobronchially, and within the endobronchial world, if it is a simple isolated carcinoid, you can do what is called as lasering. You can do cryotherapy, you can do diathermy, and occasionally you might have to use stenting. Okay, so this stenting is used when it's blocking all of the airway. So you put it in to allow the lung to re-expand. So after lasering, if it is a broad-based carcinoid, you can actually put in a stent, and that will prevent the carcinoid from coming back. And we have done all of these. Of course, the important thing to remember is if there is a tumor in the bronchus and you have actually subjected it to endobronchial lasering, then subsequent surgery becomes very difficult, because that tissue when you try to re-anastomose or you try to put a stapler on it, there is a high risk of bronchopleural fistula. So before you go down the route of endobronchial lasering, you got to be very careful to assess whether this patient is operable or not operable. If it is operable, my best chance is to give them surgery. But sometimes you get these patients who are inoperable or who are not fit for surgery, then you can offer them endobronchial lasering as a therapy. I'll just show you this video. This is Khalid Amer's video on how he does tracheal laser bronchoscopy and stenting. Now, this is not a typical carcinoid. This is an atypical tumor which has grown and also shows evidence of metastases. And it is actually showing blockage of the airway. You can see that. So this is Mr. Amer's editing. He has used this tumor. He's used this video many times in our talks, and he's also given me permission to use it. So here he is using a laser. Now there are many types of lasers, and I have spoken today to Dr. Tushar Shah, and we are going to do a talk for you specifically on lasers. The laser that we use at Southampton is ND-YAG laser, okay, ND-YAG laser, and that works very well. But there are many other lasers out there, CO2 lasers and holmium lasers, and there are specific indications for specific lasers in different specialties within the world. Now, this is a very old video. To be really honest, I would never ever use that metallic stent. Okay, I just showed you the metallic stent. Nowadays, we've almost given up on using metallic stents. What we use are nitinol stents. The nitinol stent has a predetermined memory. So when you get in there and you expand it, the heat of the body allows it to re-expand over 24 hours and achieve maximum opening. The metallic stents are given up completely because the metallic stents can erode through the trachea or the bronchus. And we've had a couple of cases where we had tracheo-brachiocephalic fistula, we've had tracheo-aortic fistula, and these guys will suddenly bleed to death because the stent has eroded across the trachea. So metallic stents are almost given up. Nowadays, it is only, nowadays we use nitinol stents, or we will use silicone stents. The silicone stents are new stents, and when I do the talk on stenting and lasering, we'll talk about these stents more. Now, this is a patient who came in with the obstruction. You can see the distal area is completely obstructed, and this is following the lasering and stenting, and the lung reopens. Now, these are palliative measures. This was not a patient in whom I was thinking about resectable surgery. So this was not a good case for surgery. Now, there are certain prognostic factors within histology. As I said, histology is the most important thing in carcinoids. A good histopathologist is needed to make a good diagnosis. The negative prognostic factors for histology are a size more than 3.5, high mitotic rate, evidence of pleomorphism, and evidence of erogenous spread. Okay, these are quite important negative prognostic factors. So what is the prognosis of this disease? Look at it. If it's a localized disease, you have an 84% 5-year survival rate. So that's pretty good. Even if you've got regional disease, well, that means that the lymph node is spread to the local region, you have a 72% 5-year survival. So even if you've got an atypical carcinoid, you must treat these patients aggressively. And of course, if you've got distant metastases, then obviously the survival goes down dramatically, and a 5-year survival is about 27%. So it is very important to treat these disease aggressively, because you get a very good survival with this. Reassessment is a CT scan, but personally nowadays I've changed that to do a DOTA PET. I personally like to follow up these patients with a DOTA PET scan. And usually I'll do it at 3 and 6 months post-curative surgery, because I want to make sure that there is no recurrence or new things. And then once I've done it the first 2 times, then I do it once a year for at least 5 to 7 years. So that's my follow-up for carcinoid tumors. They will keep coming to me, and in the first 1 year, I will do a DOTA PET, and after that, I might just do a simple CT to make sure there is no new lesions seen. So tracheo and bronchial tumors are frequently undiagnosed, as we said. Tissue diagnosis is very, very important, and surgery remains the mainstay of treatment. Okay, thank you guys. Okay, let's take questions. And then we'll talk a little bit about thoracic trauma if you want. Let me just stop sharing my desktop. Okay, so switch your microphones on and you can ask me questions. Give me 1 second, okay? I just need to switch off this. Let me just, who's asking?
Shashikaran, sir.
Shashikaran, come back in, tell me.
Sir, is there a concomitant chance of having a adenocarcinoma as it is seen in carcinoids in gastropancreatic carcinoids can have around 25% of adenocarcinomas?
Not common, but anything is possible. Anything is possible. If he's a smoker, for example, he's a smoker, carcinoids may have happened as a separate cause, but smoking can give rise to edema. So anything is possible. That's why you have to have histology when you have 2 lesions.
And if the biopsy is atypical carcinoids, should we go ahead and do a PET CT or only DOTA PET is enough?
No, a DOTA PET is what you do. If you're dealing with carcinoids, I will only do DOTA PET directly. I don't do DOTA PET is also a PET CT, except that the dye that they use is a DOTA. DOTA. I don't remember the full form of it. You can look it up online. You know, it's one of those long names, something oxy, blah 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 blah, whatever. You know what I mean? It's one of those. It's the name is it's the name of a molecule. So just like an FDG, so PET can be done in many ways. There are many different molecules in a PET scan that you can use depending upon the type of tumor you're dealing with. So more and more the people are looking at various forms of PET scans. In India, in Delhi particularly, DOTA PET is freely available. My hospital doesn't have it, but Apollo's got it. I think Mahajan Imaging can do a DOTA PET if I'm not mistaken. So DOTA PET is available, and I will do DOTA PET always. That's my investigation of choice. Okay.
And sir, sorry. Is there a chance that we should when we are planning for sleeve and the lesion is too large for as a intervening measure you need to do an endobronchial procedure and then go ahead with a sleeve resection or something?
Yeah.
But as you told that endobronchial
where the problem, you can do that. Some people do that. They reduce the size of. See, usually you do the lasering when this guy comes in acute stridor. That is the problem. This guy comes into the A&E, he's acute stridor, about to have a respiratory arrest. You go in with a bronchoscopy, do your endobronchial procedure, put in a stent and just come out because you're trying to salvage the movement. But the problem is it does make it difficult for surgery afterwards. There is no doubt about it. But it doesn't mean that it makes it impossible. You can do surgery afterwards. That's not a problem. But as a surgeon, I've always found that when I try to suture a tissue which has received laser in the past, then the tissue is not good quality. There is a lot of fibrosis. And remember, most of your sleeve resection, the healing has to happen by the body's reaction. And if you try and suture a fibrotic tissue to a fibrotic tissue, your sutures are not the ones that hold things together. They just approximate till the healing happens. And laser causes fibrosis, so your healing may be delayed. And so the risk of having a fistula, a bronchopleural fistula, is higher in a laser tissue. But it depends on the clinical situation. If he's short of breath and really struggling in stridor, I will do laser. I will salvage him and then operate in future things. In Southampton, Khalid Ahmed and I have a whole series of patients whom we did not operate. Actually, we have done repeated lasers and we have followed them up over a period of time. And I have these patients still in my follow-up. In Medanta also, I have 2 patients whom I have lasered, and I have got them in my follow-up where they did not want surgery. They said, we do not want surgery. Full stop. I don't want you to go into my chest. So we lasered them, and every so often they come back, and touch wood, both of them have not got recurrences, but they will happen because I don't think we have treated the underlying tumor. We've just reduced the mass and the volumes. The recurrence will happen at some point. Okay, next, who's there? Anybody else? Any more questions? Is neuroendocrine tumor clear? Okay, this is just, I didn't have time to prepare much, so I just came and I said, 5 minutes, let me see if I can do something for you guys. So let us, instead of doing trauma, why don't I put up some questions, which I was telling you about yesterday, and you guys see if you can answer them. Is that okay? Yeah? So, okay, I'll share my screen again with you guys, and let me see if you can get some answers. And this is just for fun, okay? We'll stop the recording here.